The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, depending upon your time zone. My name is Seth Avery, and I will be conducting this webinar. In just a moment, we're going to give a couple minutes for people to log in. They may be looking for that link to try to get to it now. Just give it just a few more seconds here as people are logging in. Well, I'm going to go ahead and get started. Thank you very much for everybody that's attending today. This is the last in our educational series that we started last year, webinars. And these are webinars that we've traditionally provided through HFMA, both chapters and regions. We decided last year to just go directly to the people. Not that we're not working with HFMA and still doing webinars for them, but also just gave us another venue to get the material out. There will be a webinar next week that we kind of slipped in. It wasn't on our original schedule, but we had been getting a lot of questions and comments from our customers and friends, and our friends that are customers and vice versa, about pricing transparency. So we thought we'd do a short webinar, kind of updating people on what we're seeing, what we're hearing, how people are responding to the new mandate. So you may want to join that. And I believe it's next Wednesday at the exact same time. And you should have gotten a link to that. If not, you can go out to Centauri Health Solutions and find it there. But please join us. And then we will be announcing probably sometime in March another series of webinars. We're putting topics together for that now. Some of them will be repeats, but always happy to entertain suggestions for topics. And if I'm not the right speaker, we'll find the right speaker for that. So please, love to get your communication on things that you think need to be addressed in the webinar format. Because at least for the next few months, we're all kind of stuck in the webinar format until we can all get back together for live face-to-face education. Okay, so with that, let me get rolling here. Basically, that's just me. And then there's pictures of myself and our Vice President of Customer Engagement, Rhonda Caliban, who helps me put these together also. And then again, there's our note about our next webinar on pricing transparency. So this webinar is, I started this webinar a few years ago, and I've tried to keep it updated. What I found, let's see, I have to go back a little bit in history. About 6 or 7 years ago, I started developing a denials management tool to add to our list of tools at AppRev. And I had to go very, very far down the rabbit hole of ANSI data, how payers use it, how providers use it. And what I found when I started talking to people about denials is that many of my customers did not understand the basics of the data. they understood what their hospital information system or consultants and et cetera were giving them, but they didn't really understand the core. And sometimes the understanding those little tiny idiosyncrasies of the data helps you to perform better in your denials management. I guess that's basically the only way to say it. So I decided to kind of take it back to basics. So a lot of this presentation is we're going to be talking about those basics, what this data is, what it is not, because I think a lot of times people think it contains information that it just doesn't contain. So that's where we're going. So we're going to talk a little bit about, we're going to start with key performance indicators for denial management, talking about the basics, the codes, organizing the data, and then, how do we measure our success in denials management? Okay. So since the introduction of HIPAA, since at least 2003, you should be getting your remittances, all your payments in an ANSI 835. And I always realize there are exceptions. And over the years, and I don't see this as much, but I'll have hospitals that'll tell me, oh, well, we don't get paid electronically by that payer. We get paid in paper. And my response is usually, that payer produces the ANSI 835 remittance. You're just not processing it. So you're using the paper or you're posting it or whatever. But all of these payers produce 835s. There are some very small exceptions. And you'll always have that kind of odd payer in your mix where, it could be like if you have a direct contract with the local school board, or you see it with jails, prisons, cities, a lot of government entities that are paying you directly may not be remitting in this format. Other exceptions, sometimes workers' comps in states avoid this. But by and large, if you're getting paper from a payer, it's worth investigating whether you should be getting it electronically, and then you really should be up on all of your payers in electronic format. And the reason is, some of it's really obvious. It's far more efficient to let the machine push it through and post it electronically. You get all of that data that we're going to talk about available to you to be able to look at what's going on with your remittances. And of course, the paper is just time consuming, and hopefully you don't have a lot of it. We do not do this, but there are a number of vendors that will convert. If you have a payer that cannot produce an electronic format, there are vendors out there that will do a great job of converting it to an 835. I have one customer in particular that they get a number of their payments still in paper. They've got a vendor that does it. When it comes to our system, we couldn't tell that it had started out as paper. So there are some really high quality products out there for that. And again, we're gonna get into a little bit more of that detail. So you may have your own list of key performance indicators, but this goes back to the idea of, if you're going to manage a process, then you should know when you're managing it successfully and when you're not. And that's what our key performance indicators are about. So I like to look at, and again, I'll get into a little bit more definition of this as we go through, what we call zero pay denials, partial pay denials, total denial rate, which is the sum of those two, and then the percentage of recovery by the number of denials, and percentage of recovery by denied dollars. And then also, I like to look at your average recovery, because if you understand what your average recovery is, and assuming you're not going to work all your denials, because nobody ever does, you want to work the ones that are going to give you the greatest return for effort. So average recovery is a nice little statistic that you can use to gauge how successful you are at picking the right denials to work. And sometimes it's small dollar ones, that you can turn over really quickly, but you need to know where the big dollar ones are that you can get to. Okay, so ANSI 835 is a standard data set. It's not the most complex ANSI data set. your ANSI 837, which is your claim format, is far more complex. 835 is fairly simple compared to the 837. If you've never looked at the implementation guide, which you can, there are several websites that basically sell the implementation guides, but it's about 125-page implementation guide. I used to keep I have it on my desktop, but I used to keep a printed out copy of it with like little sticky notes on page after page with my notes as I was, again, diving into this process and building the system. It's a very powerful data set, again, that gives you a lot of information. It tells you, basically, it gives you your payment information. So if you think of your billing system as really an accounts receivable, it's an accounting system. So you send out claims, which are essentially, from an accounting perspective, sales. Then you get payments back, and you're basically going to, you're going to debit your cash and credit your AR for the accountants out there. And this electronic transaction is going to give you all the pieces to know how to make those adjustments in your accounting system. It should tell you the reason for those adjustments. So one of the adjustments is going to be for a payment. So you should have all these payments that add up to a wire transfer or a physical check. Then it's going to tell you things like why you weren't paid 100% of what you billed. If you do get paid 100% of what you billed, that's another problem that I'll address in another webinar. But if you got paid 100% of what you billed, you probably have a lesser of issue. And if you're not familiar with that, you can go to our website and look at that. We have an article out on lesser of that you can look at. We do webinars on lesser of. But if you're not getting paid 100%, then the 835 is going to give you back in that electronic transaction those adjustments. And we're going to walk through those a little bit, but generally they're contractuals. You build 100, you're only expecting 60 back. They give you $40 back in adjustments, $60 back in payment. And then it's going to split it between what the insurance company is paying you and what they're telling you to bill the patient. So it comes back in those two separate fields. Now, clearly, the one that is the insurance payment, those should all total in that file to the payment, whether, again, it's usually electronic transfer now. So I know that's a lot of information, but that's giving the sense of really what we're looking at. So again, this typical ANSI data set, it's going to come in a file, which if you ever look at the raw files, they're generally asterisk delimited files. They don't have to be asterisk, it's just that's the most common way that people delimit ANSI files. And when you're looking at that, we're looking for payments, adjustments, and remarks. So we have these different codes, and in the presentation, and we can get you the presentation also. If you go to the WEDI site, they keep the updated list and definitions. Whoops, I'm sorry, I just hit that. They give you definitions of these codes, and we'll talk a little bit about how that works. But last time I looked, there were 988 remittance advice remark codes and 263 claim adjustment reason codes. So every 835 is going to have a claim adjustment reason code, or CARC, but not all payers use the remittance advice remark codes. And we'll go through some examples of those. But the RARCs, or the remittance advice remark codes, are generally used by governmental payers. So Medicare uses them, quite often Medicaid uses them, sometimes your managed Medicare or Medicaid may or may not use them. Don't see the commercial payers using them very much. But again, they give you a slightly different level of information than just an adjustment. And the claim adjustment reason codes, it's very important to know this. they can be either at the claim or at the service level. So what I mean by that is when you get a 835 back, if it's claim level codes, then there's not going to be any service level. It's a either or. It's not a mixture. I've never seen a mixture. Maybe somebody out there has seen somebody push through a mixture, but it should be an either or, either claim level or service level. So at the claim level, what it's telling you is this adjustment applies to everything on the claim. At the service level, it's going to be posted line by line, essentially, when you try to line up the remit and the claim. Now, an expression that I found very helpful, maybe it doesn't help you, but it certainly helped me when I was starting to go deep into this rabbit hole several years ago. You would think you would have the 837 go out as a claim, and the 835 would be essentially an echo. So you send out a bunch of information on the claim, and then the payer echoes it back. But that's not how it works. There's a lot of information on the 837 that never shows up on the 835, and you can't even track it from one to the other. So they're just not, you just can't necessarily line them up. And I'll give you an example. When you get an 835, well, let me skip it. All right, let me go through a slide. What's not on the 835? The claim source. For example, you can't tell if it's responding to professional, institutional, skilled nursing, LTAC. You can't tell who they're paying other than by simply the address and the tax ID number. Whereas on the 837, there are different formats for professional and institutional. The attending or referring physician's NPI is on the 837, but it's not on the 835. And the dates of service are not on the 835. So when we work these, there are so many dates that you have to follow. There's a date, so on 837, you have the to and from dates on the 837, which are essentially your dates of service. You have the statement date, you have the transaction date. There's just a lot of dates, but again, there's not an echo there. Okay, now I put some polls in here, and the idea was to keep everybody awake and paying attention. So let me launch the poll here, and here it goes. First question is just a very simple one. If you're a provider, and you can answer this even if you're not a provider, do you have a separate denials management team? And again, what I'm asking is, it's just a question of, some people embed this into their everyday routine of their either billers or follow-up teams, and then others basically do it as a separate function. You know, like with revenue integrity, quite often people create a separate revenue integrity function. All right, I'll give it one more second. Okay, let's see. All right. Let's see, so I closed the poll. Now we'll share the results. Yeah, so most people, 72% said they have a separate function for our denials management team. That's pretty typical. I think 10 or 15 years ago, we would have gotten a very different answer. But again, very, very similar to revenue integrity, where people are seeing these as almost like a core set of competencies or a different focus for everyone. Okay, so moving along here. Denial basics. I know you're thinking, wow, we just did the basics. So there are different ways people identify denial. And I'm going to talk a little bit about how we do that and why I think it's useful. But what I would say is the typical hospital information system looks at the claim adjustment reason codes on the remittance and decides if it's a denial. And there may be multiple, remember, these cards can be posted at the service line item level. So there's quite often multiple claim adjustment reason codes on a remittance. And if you think about it, You get some that have payments and denials. So again, you're going to get a blend of codes on there. And we'll go through some examples. Healthcare Financial Management Association splits denials like we do into zero pay and partial pay denials. And then we generally, like I said, we track that. Now, my definition of a zero pay denial, and this is very technical definition, is I take all of the remittances and claims that go together and put them in one group, and I call it a claim group. Because I know this is going to shock people, but you quite often put out more than one 837, one claim for a service. You may have late charges, you may have a void and replace, and you may have a void claim. Different claims types that go out. We pull those all together, and then what I do is I balance them. So I take what's in the CLPO4 on the remits, which is the payer payment field, and CLPO5, which is the patient responsibility field. And if those two add up to zero, then I call it a zero pay denial. Because in my view, the payer has valued it as a zero. If there's a payment on there, in other words, a greater value than zero, but it has a status indicator of 4, which means denial, then we call it a partial pay denial. So that's how we look at it, because there are a number of remittances that come in that the only claim adjustment reason code that's on them is a payment code. Like primary payment is 1, I think coinsurance is 2, secondary is 3. And those will be the only ones on there, but there'll be no payment. So we try to draw those to the attention of our customers also. The trick is you have to exclude the ones that look like a denial, but they're not really a denial. And one of the best examples of that is Medicare shadow claims. And if you're not familiar with this concept, these are when you have a managed Medicare patient for inpatient, and you're a DSH, or a disproportionate share receiving hospital, which is an additional payment for hospitals that have a disproportionate share of either indigent or Medicaid days. So if you're a DSH receiving hospital, you have to send Medicare basically a shadow claim to let them know how many days you had with a Medicare Advantage patient. Because otherwise, Medicare never knows how many days you actually had, and they can't calculate your DSH payments correctly. And this was born out of a gigantic lawsuit, I don't know how many years ago now, but this did cause people not to get cost reports settled for years while they sorted this out. So there are ways of identifying this. So for example, if you use a bill type 110 and send it out, in our system, we would just ignore what would look like a denial. And we do this with a number of other things that look like denials as to how we track them, but they're not really. And an example would be as you get like a CARC 45, which is a fee schedule adjustment. If you get a fee schedule adjustment on a Medicaid secondary remittance, we know it's just Medicaid saying you already got paid by the primary as much or more than we would have paid you as a secondary, so there's no liability for Medicaid. Those aren't really denials. There's nothing for you to do with them. They're not actionable, so we would ignore that as a denial. So it's just as important as you identify denials to know which ones really aren't denials and which ones are not actionable. So this is just some examples of, if you go through it, identifying shadow claims. And we've got all these ways we've learned over the years, because sometimes our customers will not send out the 110 bill type, or the payers respond in such a bizarre way that we've learned different combinations of CARCs and RARCs and status codes to figure out what are really shadow claim returns. Okay, all right. Yeah, so here's some other examples of things that we ignore. And this is a really strange one that came up when we had the government shut down, and I'm trying to remember the year, I think it was 2014. Don't quote me on that, but I think it was 2014. There was born out of there basically a holdback from Medicare called the sequestration. And there's a CART for that, CART 253, which is sequestration, it's just basically telling you they're taking an adjustment on your Medicare payment for this sequestration rule. So when we see those for Medicare, I mean, they just get ignored. But the funny thing was, I started looking at it with some of my customers, and some of the managed Medicare were taking the same adjustment. And, you know, we went back and said, just want to point this out to you. I don't know what your agreement says, but I don't know if they should be getting the same adjustment that Medicaid or that Medicare is taking. And then this is the example we talked about earlier, where you get a CLPO2, which is a claim status code of 2 for secondary payment, and you get it from CART 45, which is fee schedule lessons with Medicaid. Again, it's not really, there's nothing actionable there. So we're trying to get to, in our understanding or denials, what are the ones we really should be working. Okay. There's no really hard and fast rule on what is an appropriate denial rate. I will tell you that in different states with different payers, you see different rates. It's most of my customers and people that I've done this work on, I see a denial rate of around, based on claim number, you know, 7-8% is pretty typical. Strangely, for those of you who live in California, every time I run this in California, the denial rates approach 20%. I will tell you correspondingly that the recovery rates are much higher in California also. So there seems to be a tremendous amount of churning going on in California on this. All right, again, and again, partial pay, the way we identify that partial pay is claim status of 4. Again, these are just some metrics on how you calculate it. It's very simple. Partially paid total claims gives us our partial pay rate. And then denials overturned. Again, HFMA put out this thing of 40 to 60%. I don't know where they got that number, because I generally see less than 10% of what we identify as denials actually ever getting overturned. And a lot of them are just high volume things that people never mess with. And what I try to do is get people to tweak it. So if it's stuff you're not going to mess with, let's just get it out of the system. Let's focus on the stuff that's really interesting to you. But I know when HFMA came up with this 40 to 60% years ago, it just seemed very high. Okay. All right, we're going to go to organizing the data. So you get your remits, your denials are generally identified by the claim adjustment reason code. And then if you're working them, they're distributed by claim adjustment reason code. So there's a little bit of complexity here. What do you do if there's multiple claim adjustment reason codes? I'll give you an example. CART 29 is timely filing. So I'm trying to get them right now, 16 or 18 off the top of my head, is missing information. So if you get both of those, what I generally tell people when they start looking at this is I would resolve the timely filing first, because there's no point in looking for the missing information or trying to figure out what the payer is looking for if in fact it's just going to be denied for timely filing. What I do is I take our data that we produce for the customer and I just overlay it with a very simple fact. I get all the timely filing or refiling dates, you know, if it's 90 days, 180 days, or a year, whatever that number is, and I just overlay that number and I look at the data, the remit, which we have in our analysis, and then it's a true or false. then you know, did you actually miss the timely filing or did you not? So that's very easy to do. But the second part of it is I have a customer that says, we don't care. We pursue every one of those, even if we miss the time of filing, and they recover on them. So I cannot argue with their success. But it's just something to think about how you're dealing with multiple claim adjustment reason codes. And again, this is just an example of, this one has, again, this is, you see, this has been remitted on 4 different dates. And then at the end, it was actually paid and then reversed 2 months later. It was denied. It got a $52 payment in July, and then was subsequently denied on the same one, and then reversed. So this is just one I pulled out of here. It's just an example of how crazy this stuff can be in the data. This is an example, again, this is just a way of looking at the data. This is how we organize it, but see on the left, you'll see if it had a claim level adjustment, that would appear on the left, but then on the right, it's service level adjustment. So for each line in the remit, you can see it's got its own adjustment. And in this case, it's got a 45, which is a fee schedule adjustment. Now, again, the fee schedule adjustment goes back to that other one, which is, it's basically the entire amount of the charge, and then it's been reversed with a 22. It's always good to look, to look at the status code 22 is your reversal code, and that's always interesting to understand that. Here's another example of one where it's a CARC 18, which is duplicates. So a good way to look to spend some time diagnosing the efficiency or efficacy of your billing is at least to look at from your payers how many 18 and how many 29s you're getting. So 18 is duplicate. We've had people before that had a tremendous number of these 18s coming back. And what we found was they really didn't know how to rebill. The way rebilling works, and again, I'll try not to go too far down this rabbit hole, but when you send out an initial claim, if you send out a follow-up claim, you include, there's a field on the 837 where you include one of two things. You either include the original claim number in that field, or you include a payer control number, which has come back in a remit. So you send out a claim, if you got a remit back, the payer sends a payer control number that goes into your 837, and that's how the payer links those together and knows that it's not a duplicate claim, that it's an update to a previously filed claim. So there is some linkage there that happens behind the scenes, but if it's not set up right, you get a lot of these because they think you're not updating their claim, they think you're sending them on a duplicate claim. Okay, just another question here to make sure you're still paying attention. This is kind of a more subjective question here. So, do you feel comfortable with your denials management program? Again, it's just a subjective question, you know. Maybe I need to spend more time writing questions, but it just gives you something to think about. I probably should have a question that says, how many of you are involved in your denials management program? That would be a good one too. All right, let's see. Let's close the poll, share the results. So most people are happy with it. That's great. It's got to be one of the most challenging areas to work in the revenue cycle. That's for sure. Okay, so now let's talk a little bit about measuring success. And again, oh, you know, one thing I didn't mention, if you have questions, you can submit questions as we go along. And I will probably address them at the end. I try not to look at the questions as we're going through here because I get easily distracted. All right, so now that you've got all your data organized and you got it by CARCs or however you're doing it, what are you gonna do with it? And again, you can't work all of them. So how do you decide which ones to work on? Do you have an ability to look at your success and your returns and filter out the ones that are unproductive? And do you have the ability to work them in batches? And what I mean by batches is, I have in the past, when I worked in hospitals, find that you have a particular denial issue with a specific payer. So instead of working them one at a time, I actually bundled up a big package of them and negotiated, a payment for that entire issue. That's possible. Again, it's driven by circumstances, but at least you should be considering, if you spot a trend like a payer makes a change in how they're interpreting something, you disagree, you can come to a resolution and work it all at once, and rather than one by one by one. And this is just an example of this is something that you could potentially, if you had a bunch of these working in batch. As you remember, Medicare moved off the CPT level 1 code for E&Ms back in 2015 and went to G0463, which I think is still the current code for OPPS hospitals. What I found was, with some of my customers, is they made those changes for other payers and then didn't make changes for other payers. So for example, a managed Medicare program may have said, yeah, we're also going to make that change, and they were still billing the 99201 instead of the G0463, or the other way around. It could have gone either way. They could have needed to make the change, not made it, or made the change on that payer and we're sending them the G0463, for which they didn't have a negotiated rate, et cetera. But you can see that this is an issue that you could bundle up and try to get resolved essentially all at once. Okay. Yeah, and this is just an example. When you see the CARC 97, which is, it's actually the CARC 96 is like non-covered service. 97 actually is called bundling. And it's not bundling in the way we think of it. What it really means is the payer is supposed to, with the 97, be telling you that they are not paying you based on the code you submitted, they're paying you based on a different code. So in this case, they also put a RARC on here that says the drug service supply is not included in the fee schedule or contracted legislative fee. So again, it's just they're telling you that this G0463, they don't know what it is and they don't know why you're billing them that. Now, some payers in an automated fashion will take that CARC 97 and you'll see coming back on the remit that they changed it to a 99201. And a lot of times providers don't even know that payers have the ability, and they'll call it upcoding, downcoding, but if they're doing it, they should put if they're doing it and they're following the implementation guide, they should be putting a CARC 97 on it. See, eventually you will memorize all these CARCs, and then you'll have a favorite CARC. And when I used to give this presentation in person, I'd always say my favorite CARC was CARC 13. And for those of you who probably are not familiar with what CARC 13 is, it is date of death precedes date of service. So as I would jokingly say, unless you have an active resurrection program at your hospital, something's probably wrong with the claim. And what you'll find is when you see a CARC 13, it's probably the most overturned denial, because it's generally a case of you just have the wrong service date, because you're not performing services on deceased patients generally and billing for them. So you'll get to know these, and you'll develop your favorite list of CARCs. All right, so when we look at how we are breaking down our denials, I generally put them in two gigantic categories first. Really administrative versus clinical. And what that's doing is that's my first cut as to how I'm going to track it. and who's going to work it. And the next ones, I break them down into a little bit more detail, like eligibility. Like, am I having problems with eligibility denials? And then now my third part would be who actually, if I'm going to have eligibility, do I have a specific group that works on that? Do I do it by payer? For example, if you can organize your data really well, do you want to have somebody work eligibility, but you want to be able to track the source of those eligibility errors? So a lot of times what I do in our system is we match up the revenue code for the hospitals with the denial. So I can tell whether they have a 450 revenue code on it, which means they went through the emergency department, whether they have, you know, like a 360, they went through surgery, et cetera. But you can look at the revenue codes and actually have a good idea of probably where that patient first touched eligibility and potentially who's going to work it, but also I can go back to my source and try to figure out what did the emergency department miss, or is it just a payer error? Is the eligibility correct and I've just got a payer issue, which, you know, it could be either one. Okay, next is talking, again, we're breaking it down. We start at that high level, then put it in by category, and then we can go all the way down to the specific CARC and work it that way. For example, 16 is missing info, but some payers use another CARC 252, which is missing attachment. Some of them use them interchangeably, but if you get a Blue Cross for an inpatient that has a 252, you might have a really good idea of exactly what they're asking you for. That may mean every time that you see that, they want an op report or an op summary. So if you know that, one, you know now how to resolve the denial. Secondly, you know how to avoid it, because now, you know, with the 5010 standard of the 837, you can include an op report with the claim as an attachment. So don't do like what a bunch of hospitals in Florida did when they rolled out the 5010. They started sending the entire medical record to Blue Cross. Blue Cross did not appreciate that. Well, really, all they want is the op report or the op summary. And if you know that, now you've resolved the denial and potentially avoided them in the future. And you want to, again, develop that workflow by looking at hierarchy. In other words, where does it go first? What the priority is? Are you successful at that? Are there other factors driving that? And are you working issues or are you working individual remits? And again, these are just some examples of where this is going. Coding, case management, registration, billing. It's just different ways of organizing that work. And again, do you work them, and what order do you work them in? All right, last poll question. You're almost out of here. What would you say your denial rate is? And you know, kind of a follow-up mental question there is, where would you even get that information? Who's calculating that? Where is that coming from? Something to think about. So I know when I launch the polls, people suddenly always get more interested. Okay, I'm going to close that and share the results. Yeah, so most people think it's between 5 and 10%. I'd say that's probably a pretty good guess. And I see 33% say over 10%. That must be the people in California. They know the truth. But yeah, that's the pretty standard. Somewhere I'd say 8 or 9% for most hospitals is pretty typical. And physician groups, it's kind of all over the board. I've seen it as low as 2% and as high as 20%. Okay, so just a last little thing. These are just some things to think about. Metrics on success. When do you win? What are the issues? Were you not successful? And the ones where you're not successful, I mean, this is the tough thing. It's like do you put more effort into it or do you put less effort into it? And that, it's just driven by the issues. There's no magic bean, there's no silver bullet, there's no perfect answer. Yeah, sometimes where you're not successful, it's just things you're not going to overturn, things you're not going to win on. And again, we talked a little bit about KPIs at the beginning, total recoveries, percentage of denied claims by dollars, average recoveries, and what's your trend? Is it going the right way? These are my deep thoughts for today. Is total recoveries down is good if there's a corresponding reduction in the denial rate and if it's greater than the reduction in the recovery rate. So basically, it's okay if recoveries are going down if you're solving the problem, because you should be seeing that in your payments rather than your denied recoveries. They should just be flowing it through without that average. And again, watch the average recovery compared to the recovery rates. And average recovery shows if you're hitting the best ones. Or it can. I mean, these aren't completely dispositive. Okay. All right. All right. We have spent about 45 minutes, or you've spent 45 minutes listening to me. If you have any questions, all right, let's see. Let me start. I got a few here. All right, first question. Any tips or tricks for working Medicare Advantage claims? We do not have contracts with any Medicare Advantage plans. They take big adjustments, around 70 cents. We send them our Medicare interim rates, but we still have issues with getting them paid with what Medicare should have paid. That, you know what, that is a great, wow. There's got to be some term to describe that. I'm not sure if chutzpah is the correct term, but I think that was one. If it was me, I would try to come up with a dollar impact. And you may have already done this, but I certainly would think about getting legal counsel involved in that. If you don't have a contract with them and they're doing that, and I don't know the current law on whether you can bill the patients, but if you can, and I'm not saying to bill the patients to balance, not saying that, but it's a good threat. But I might get legal involved, and I would try to bundle those up and get a settlement. And then certainly if you want to get a contract with them, which it sounds like you'd be better off with the Medicare rates than what they're paying you, again, that may be something with legal counsel. But yeah, I would take that as a single batch issue with those payers. But I think that's the only trick to it is, I mean, what do they say? Lawyers, guns, and money, right? Okay. So now the next question is from a California person here. Our denial programs are shifting from final denials to initial denials. Final denials are tracked by CDM codes. The billers collectors enter to help us track and manage denials. Our shift to initial denials from the 835 are interesting. There's certainly a lot of noise, yes, codes to filter out. So yes, more of a comment, but no, you're absolutely right. And that's part of what I was talking about at the beginning, and hopefully it came through, is on the initial denials, there's a lot of noise and it's filtering through. And like when we implement our solution with customers, it generally takes several runs to filter out a lot of that noise. And then when you go back to the people that are working them, they're still going to provide you more filters to that noise, because it's imperative you get down to the ones that you really want to work and that you really want to track, because yeah, again, just like you said, that noise is out there. It's hard to filter. But that's an iterative process. One of the things we do is also, I run a report for the customers every month that is, all it is, and actually the idea for this one came from a customer, and all they wanted to know was what changed from the prior month. And what they were trying to do was identify where the payers or either they inadvertently or the payers overtly made a change. And so suddenly CARC 140, patient ID blows up with a payer. And if you're not looking at it that way, you might be 3 months down the road before you figure out that there's been a change. So it gives you that ability immediately to address and try to, again, more information. You got lots of data, but you're trying to turn it into actionable information. No, but great comments. If you have follow-up questions, comments, ideas for webinars, comments about this webinar, that would be great. Love to hear from you guys. And other than that, I'm going to release you back to your day. And thank you very much for attending. And I hope you attend future webinars.